Bismillahirrahmanirrahim. This video will demonstrate the nervous system examination, which is meant to teach medical students and residents. In this video, we'll go through the process and steps of the nervous system examination, starting with the mental status examination, cranial nerve examinations, motor, sensory, gait, and coordination. The best advice to use this video is to watch it and then you practice the steps shown in these videos. This video will only show the techniques of the nervous system examination, but we will not demonstrate any abnormal findings. As a general rule, you should always be organized when performing any examinations, and particularly the nervous system examination. So you have to start with a system and follow that system. For example, you have to start with inspection and then go through the next steps. You always need to compare both sides, and if you examine any nerve, you should always think of it as a nerve that has three components: motor, sensory, and reflexes. Although not all the nerves has these three components, but this is a way to really make your life easy to think of any examination of particular nerves. In this video, we'll demonstrate the examination of the mental status, which consists of examination of orientation, attention, memory, language, and praxis. In this section, we will do the orientation examination. ممكن تعرف على اسمك؟
محمد الشهري.
الله يحييك محمد. انت فين موجود الان يا محمد؟
موجود في مستشفى عسير.
فين مكان المستشفى؟
في أبها.
في ابها. ابها في اي منطقه؟
منطقة عسير.
في اي دوله؟
في المملكة العربية السعودية.
السعوديه في اي قاره؟
قارة آسيا.
طيب الان بدون ما تطالع في الساعه، تقريبا كم الوقت الان؟
تقريبا حدود 10.
10 صباح ولا مساء؟
لا مساء.
So he's oriented to time, place and person. Now I will do attention examination. محمد أبغاك تقول الأرقام هذه ورايا. 7 5 9 3 6.
7 5 9 3 6.
ممكن تقولها بالعكس.
6 3 9 5 7.
So by this technique I use digit span to examine the attention. I give him 5 digits. I ask the subject to list them forward. To make it even more difficult, I ask him to do it backward. The next exam is the memory examination, which has 3 components: immediate memory, short-term memory, and long-term memory. I have already examined the immediate memory through the digit span. As he was attentive, he also has a normal immediate memory. But I will also show other techniques to examine immediate memory. أبغى أعطيك 3 أشياء أبغاك تقول لي هي، بعدين أبغى أعطيك 5 دقائق أسألك عنها بعدين.
أوكي.
طيب فاحفظها. طيب تفاحة، كرم، سيارة.
أوكي. تفاحة، كرم، سيارة.
طيب احفظ ال3 هذه الأشياء. حأسألك عنها بعدها بعد 5 دقائق تقريبا. محمد الآن أبغى أسألك في أشياء قد تكون معلومات عامة وقد تكون أشياء خاصة. أنا هذا جزء من فحصي للذاكرة.
أوكي.
محمد أنت فين تولدت؟
تولدت في الخميس مشيت.
عام كم؟
1411.
طيب ومتى دخلت كلية الطب؟
تقريبا عام 1430.
طيب محمد من الملك الحالي للسعودية؟
الملك سلمان الله يحفظه.
ومين كان الملك اللي قبل الملك سلمان؟
الملك عبد الله رحمة الله عليه.
طيب محمد مين فاز بكأس العالم الأخير؟
ألمانيا.
مع مين لعبت في النهائي؟
تقريبا الأرجنتين.
الأرجنتين. وفين كان كأس العالم؟
في البرازيل.
في البرازيل. محمد الحرب العالمية الثانية من كان قائد القوات النازية؟ هتلر. طيب محمد تذكر الأشياء الثلاث اللي قلت لك أسألك عنها؟
تقريبا أيوه.
تفضل.
تفاحة، سيارة، كرم.
Now I examine the 3 types of the memory. With the immediate memory, I ask him to recall the 3 items given to him immediately, which is also the same way that when I examine the digit span. The short-term memory, I give him 3 items, and I told him that I'm going to ask you about it in 5 minutes. Then I distracted him by examining the long-term memory, which is general facts, personal information. It should take you more than 5 minutes, and then I should go back to the 3 items. There are other ways to examine the short-term memories, such as asking where did you park the car, what did you have for the breakfast. Make sure you have somebody who can verify the information given by the subject. So it's better to avoid this by giving him 3 standardized items. Next is the language examination, which has 6 components: fluency, comprehension, repetition, naming, reading and writing. Reading and writing will be influenced by the patient's level of education. So if you are dealing with somebody who never read or write, just avoid these 2 parts of the examination. أبغاك تقول لي إيش سويت من أول ما صحيت الصباح اليوم؟
تقريبا صحيت على الساعة 10. جلست مع الأهل كذا إلى قرابة الصلاة. توضيت وطلعت أنا والوالد صلينا في المسجد. رجعت بعد الصلاة. أخذت لي نومة كذا بسيطة إلى صلاة العصر. صليت طلعت من البيت خلصت بعض الأشغال. رجعت قبل الفطور. أفطرت مع الأهل. وبعدها جلست تلفزيون بعد العشاء وصلت هنا.
الآن أنا بقول لك سوي أشياء فتابع معي أنت.
أوكي.
ارفع يديك اليمين فوق، حسب تنزلها. يدك اليسار المس بها إذنك اليمين. محمد حط يدك اليمين على راسك وغمض عينك. طيب محمد كرر معي الجملة هذه.
أوكي.
اليوم 7 رمضان 1436.
اليوم 7 رمضان 1436.
شكرا لك. محمد إيش هذا؟
هذا قلم.
إيش اللون هذا محمد؟
أسود.
طيب إيش هذه محمد؟
هذه ساعة.
طيب إيش الجزء من الساعة هذا؟
معدني.
إيش الجزء؟
عقارب.
تمام. إيش هذا محمد؟
ثوب.
To examine reading, I can give him a newspaper. I ask him to read the headlines. To examine writing, I give him a piece of paper and a pen, and I ask him to write a sentence. So now I examined language, and he has a normal fluency. I ask him to follow a few steps command, and he has a normal comprehension. Repetition, I give him a sentence, and I ask him to repeat it immediately. He was able to name different objects. He was able to read and write. Next, I will do praxis, which is examination of apraxia. محمد لو الآن معك مشط في يدك، كيف نشط شعرك؟ تمام. طيب لو معك افترض إنه في يدك فرشة أسنان، كيف تفرش أسنانك؟ مظبوط. لو أنت عسكري، كيف تسوي تحية عسكرية؟ So the next examination is the cranial nerve examination. As we know, there are 12 cranial nerves. You should go through them thoroughly from the first cranial nerve to the 12th cranial nerve. These nerves are olfactory nerve, optic nerve, oculomotor, trochlear, trigeminal, abducent nerve, facial, vestibulocochlear, glossopharyngeal, vagus nerve, accessory nerve, and hypoglossal nerve. First, we start with the olfactory nerve. To examine the olfactory nerve, you should get a non-irritating common odor, and you should ask the patient to smell it in each nostril separately. Remember, it should be a non-irritating odor. محمد الآن أبغى أعطيك أشياء تشمها. هي أبغاك تغمض عينك وتشمها، وأبغاك كل مرة تستخدم يعني جهة من الأنف. طيب الآن أبغاك تغطي لي اليسار. أيوه حاول خذ كذا شمة كذا واحدة.
أوكي. فانيليا.
فانيليا. طيب الآن الجهة الثانية قفل أيوه وغمض عينك. This is a different item to smell. شو محمد؟
Coffee.
Coffee. So he has a normal smell in both nostrils. Next will be the optic nerve examination, which has 5 components that you should examine: visual field, visual acuity, color vision, pupil response, and fundoscopy. I will start with the visual field. In order to examine the visual field properly, you should have an item that has a red cap and should be transparent. You may use a pen with a red ball at the top, and you can also use your fingers, but it's better to use any item that has a red color on a transparent stick. To examine the visual field properly, patient should have no glasses. You should be at least 1 meter or an arm stretch away from the patient. You have to examine each eye separately, and you have to use the technique confrontation, which means your patient's right eye against your left eye. We will do the technique now, and you remember to examine the 4 quadrants of each eye. Muhammad, so خليك مرتاح كده. He should be at the same level as my level, and the distance is an arm stretch. محمد غطي عينك اليمين. I will cover my left eye. طيب محمد, always look at my eyes هنا. Don't look anywhere else, just look at my eyes.
Okay.
Don't move your head, don't move your eyes. I will move this thing around the corners. When you see it, tell me I see it, okay?
Okay. I see it. I see it.
Okay. Keep looking at my eye here.
I see it. I see it.
Now, the other eye, you should cover your left eye. I will cover my right eye, and again I will examine the 4 quadrants of his right eye.
I see it.
See it, yeah?
I see it.
Keep looking at my eye here.
I see it. I see it.
Okay, thank you. This concluded the visual field examination, which was normal. Next will be the visual acuity. You should use a Snell's chart, which is a way to examine near visual acuity. You can find it, it should be at the same size. You can find it online. You can print the same size on a paper, as long as it will do the job and it has the same size. Now we'll examine the visual acuity. Muhammad, do you have any glasses?
No.
Okay. Now I will do, I need you to cover your left eye. Okay. You have to hold the Snell's chart at least 25 to 30 centimeters away from the patient. You should have a good illumination in the room. Muhammad, then you can hold it. This is a good distance. Muhammad, iqrali, should you read the first line at the top?
E.
E. طيب, go down.
F T
كمل.
L
اقرا مع بعض كده.
L B E D
Okay, carry on. تحت.
B L E O.
Okay, and green line and red line. This is the normal range. I'll get him to read this letters here. أحمد اقرا لي تحت الأخضر هذا.
F E L O.
Okay, last line اقراها كلها ورا بعضها.
D E F B O T.
The visual acuity scale. At the side of the line he was able to read. You should start with the first line, big line, and then you go all the way down to the line that he should be able to read. If he makes any mistakes or unable to read any line, you should go up to the line just before that, make sure he read it smoothly, and then the reading of that line will be his visual acuity. So Muhammad's visual acuity was 20/20. He was able to read the all lines all the way down to the smallest one. And this is 20/20 of the right eye. I should now do the left eye. Muhammad. Okay. So he's able to read the whole lines, even to the smallest one on the left eye, and the visual acuity is 20/20. So he has a normal visual acuity in both eyes, which is 20/20. Next is color vision examination, and you have to examine each eye separately. You may use Ishihara plate, but at the bedside you don't have to have it. You can simply use any color, that is the red, particularly the red, and you should compare the red saturation in each eye separately. Look at it. Is it red?
Yeah.
تمام. How about now? Still red?
Yeah.
Is there any difference?
No.
Does it look any different in any eye?
No, it's
It is the same. Next is the pupillary response. You should use any source of light. You can use a torch. Make sure the light you are using is a strong light, and you should examine each pupil separately. Look at the distance.
okay.
Okay. Now, I should direct the light in each eye separately, as I'm going to show.
Okay.
This is the direct light response of the right eye. And I can see a normal pupil response. Now I'll do the same for the left eye. Good distance. Make sure you show the light very quick and you take it off very quick. You can also swing the light between each eyes to look for the direct and indirect. Hamid, look at the distance.
Okay.
Other variation of technique, you should put a splitter so the light will not spread from one eye to the other one. And it is the same thing. Direct to the right, direct to the left, direct on the right, direct on the left. You can also, and you should look at the indirect pupil response. I will now examine the indirect response of the right eye. Look at the distance. My right light will be very faint, but the direct light should go to the left eye. I'm looking at the right eye. The right eye is constricting, dilated now. Constricting, dilating. So this is the indirect of the right eye. I should do the same now for the left eye. So now I'm going to examine the indirect response of the left eye. This is my tangential light. Muhammad, look at distance. I'm looking at the left eye. and I can see the good response of the left pupil when I shine the light directly to the right eye. So next, I will do the examination of the oculomotor, trochlear, and abducent nerve. So that are 3, 4, and 6 nerves. We lumped these 3 together because they are controlling the eye movements. When you examine these 3 nerves, you should start with inspection, and then you do the eye movement technique, which are the H technique. Sometimes you may use the X technique, and finally you have to do accumulation. I will start with inspection here. محمد كده relaxed. ايوه. لا تسوي حاجة انت، انا بس ابحث بطالع فيك. So if I want to inspect the 3, 4, and 6 nerves, I have to look for ptosis, abnormal eye movements, such as nystagmus, or any eye deviation. You may also need to comment about the pupillary size, if there are any pupillary asymmetry. So these are the major components that I should look at when I examine these 3 nerves by inspection. My next technique will be the H technique, looking for the extraocular movements. Hamad, don't move your head. Only I want you to follow my finger with your eyes only. Here I don't need to have any glasses. So and the distance is the same as about arm stretch or 1 meter. And don't move the head, only move the eyes. Follow my finger. Start at the middle, and then I go to following an H letter. Make sure you go to the extreme of gaze. Make it like a big H. Follow. You may see few nystagmus, few beats nystagmus. These are physiological nystagmus. I mean, you need to lift the eyelids, so I can look at the eyes going down. Yeah. Again, I'm going to the extreme of gaze. You may see a few beats nystagmus, but that is okay. Go up all the way, and then I go down. Follow. I go all the way down, and then I go back to the midline. So by each technique, I looked at the eye movement, at all muscles, and he has a normal extraocular movement. My final technique is to do the accommodation, looking for conversion and pupillary constriction. Follow with your eyes, don't move your head. So you should come from a distance, and then you come closer to the patients. Follow. So there is conversion, and if you look carefully, there will be some pupillary constriction. So, thank you, Mohammed. So these are the way to examine the 3, 4, and 6 cranial nerves. My next examination will be the trigeminal nerve examination. It's a little bit a complicated nerve, as it has 3 components. There will be a motor, sensory, and reflex. If you are organized and if you follow a system, you should have no difficulties performing the examination. The motor part of the trigeminal nerve is the examination of the muscles of mastications. The sensory part is through examining the facial sensation, and then the reflexes are the 2 reflexes known to be done by the trigeminal nerve. I will start with the muscles of mastications. These muscles are the temporalis muscle, the masseter, the trigoids, both median and lateral. I will perform the examination now. I want you to relax, okay? Just look straight at me, tamam? So I will start with inspection. So by inspection, I will look at the temporalis muscle in both sides, and I don't see any wasting. I don't see any fasciculation or any abnormal movements. Now, and I'm going to feel the bulk of the muscle, which is another way to look for muscle wasting. محمد عض على أسنانك clinch ارخي عض مرة ثانية. So I can feel the bulk of, thank you, I can feel the bulk of the temporalis muscle on both sides, and it looks normal. Next I will do the masseter. Ahmed, relax. The masseter is a very like a longitudinal big muscles. You can feel it if you ask the subject to clench from the teeth. Ahmed, relax. لا ارخي الآن. عض. And I can feel the muscle that should be coming longitudinally from top to bottom. محمد ارخي. Okay, so I can feel the masseter. They look both symmetric on both sides. Now we'll do examination of the trigoids. محمد افتح فمك. So by jaw opening, these are the trigoid muscles. There are median and lateral trigoid. They will help to open the jaw. محمد الآن حاول الحنك move side to side. Exactly. So this is a way to examine the trigoids again, both median and lateral, for the side to side movement of the jaw. You can also apply resistance to assess the power. محمد حاول كذا. ايوه قاومني. تمام. The other way. قاومني. تمام. So these are the muscles of mastications, the motor part of the trigeminal nerve, which is a normal examination. So he has a normal motor component of the trigeminal nerve. Next exam will be the sensory examination. The sensory examination again is the sensation over the face. Remember, the trigeminal nerve will cover the face through three divisions, which are the V1, V2, and V3, or the ophthalmic division of the trigeminal, maxillary division, and the mandibular division. Usually, we should examine each division. You have to compare side to side. You should know the anatomical landmarks of each division. I will not go through them now, but at least I will do the sensory examination of these divisions. You can use either the fine touch, you may use temperature, you may also use pinprick, like a pain sensation. Avoid to examine the vibration, because vibration will go through the bone and it will just give you a false information. So you can use touch, temperature, or pain. I'm going to use the touch, and I'm going to use like a regular tissue paper. Muhammad, I'm going to examine the sensation of the face. Always when you examine the sensation, you have to give a patient a standard, like a way to teach him what is the sensation you're expected to feel, and then you go to examine the area of interest. So I will use here the chest as my control. محمد تحس هذه؟ تمام؟ تحسها زي ايش؟ touch مش كذا؟ So now محمد بغمض عينك. I will do the exam on your face, okay? So I ask him, I did the standard, and then I get him to close his eyes. Sensory exam should be done with eyes are closed. And then I will examine each side separately. I told him I'm going to examine the face, so he won't be surprised with what I'm doing. So this is V1. تحس هنا؟
ايوه.
تحس هنا؟
Yes.
You look the same?
Yeah.
تمام. The way I'm doing it is screening, so I'm not going to really go through the landmark of each division, but I'm going to examine each division like a spot area as a screening for the exam. Eyes closed again. تحس هنا؟
Yes.
تمام. تحس هنا؟
Yeah.
You look the same?
Yep.
تمام. Now the last division. محمد تحس هنا؟
Yes.
تمام. تحس هنا؟
Yeah.
So this is the sensory part of the trigeminal. Again, I examined V1, V2, V3. I was doing screening. I compared each side to the other one. I use again the touch. You can use any other sensory modality. My last part of the sensory of the trigeminal nerve examination is the reflex. For the trigeminal nerve, we do have two reflexes that you usually examine. You can use these are the corneal reflex and the jaw jerk. I will do the corneal reflex, if you don't mind, Hamad. Okay. So for the corneal reflex, I will do each eye separately, and I will look for the blink response of each eye. Hamad. Now I will do the right cornea. Remember, it's a corneal reflex, so you should make sure that you hit the cornea. You don't hit the sclera, the white part of the eye, because it is not scleral response, it's a corneal response. So hit the cornea. Hamad. So I get him to look away from my target, because I don't want him to blink just because of the threat that he sees something coming toward him. So look away. Ahmed, look there. Oh, sorry. So I touch the right cornea and both eyes closed. Now I will do the other eye. Ahmed, مزعج الاختبار بس سامحني. Now Ahmed, look away. Look away. Again, I don't want to come in front of his face. No, I should come away. He should look away from the area I'm approaching. Okay, so I examine the corneal reflex of each eye, and he has a normal corneal response bilaterally. I will do now the jaw jerk. Relax, Muhammad. اسمع, افتح فمك شوي كذا. Open it. Make it a little bit more. Yeah, a little bit more. Relax. Relax. So I get him to open the jaw. He should be relaxed. Relax تماما. هذا hit. Thank you. So what I'm doing, he is relaxed. the mouth is not forcefully open, it's like a midway open, and I hit the mandible, of course, looking for either a jerk, which should not be an exaggerated jerk, or no response. You can have normal response with no response at all, or like minimal jaw jerk. So these are the two reflexes run through the trigeminal nerve. So overall, the trigeminal nerve is normal, with normal motor, sensory, and reflexes. The next examination is the facial nerve examination. Again, this is a very important cranial nerve that all the students and physicians should know how to examine. The facial nerve examination, as usual, it has three components. There is a motor, sensory, and reflexes. The very important part of the examination is the motor exam, which through which we will be examining the muscles of facial expression. I'll do the exam now on Muhammad. Again, when you do an examination, be organized. I will start from the top and I will go all the way down. So to examine the muscles of facial expression, Muhammad, relax. By inspection, again, I'm looking from the top and I'll go down. Muhammad, lift your eyebrows up. Eyebrows up. So now I'm going to look at the wrinkles. They look symmetric. The eyebrows elevate symmetrically. Muhammad, yes, relax. And then Muhammad, close your eyes very tight, very tight. Now, very tight eye closure. Again, I look at the eye closure, very tight. They look symmetric. I need to apply resistance to see how equal the eye closure is. Muhammad, غمض عينك. لا تخلي افتح عينك. So they look very strong, both sides. Relax, okay. Now I'm going down all the way. I will examine and have to comment about the nasolabial fold of each side. So I can see the nasolabial fold. They look symmetric. I look at the mouth. There is no drop of the angle of the mouth. Muhammad, smile. Exactly. So now I can see the nasolabial fold. They look more prominent and they look symmetric. When he smiles, there is no mouth deviation. The angle of the mouth again looks symmetric. Muhammad, open the mouth, get wide. Again, this is another way to look at the facial muscles of the mouth. So again, looking at the mouth deviation. Thank you. Now this is how tightly he can seal the mouth, and when he blows, there is no air leak from one side. Here. So again, thank you. I cannot get any air leaking from any side. So tight mouth closure look normal as well. Again, I keep going down now, Muhammad. Exactly. So now this is the way to look for the platysmus muscle, which go all the way down. This is another facial nerve examination. So by conclusion, he has a normal facial expression, which indicates a normal motor facial nerve. Next exam is the sensory examination of the facial nerve, which is a special sensation for the taste of the anterior two-thirds of the tongue. I will not show the exam, but I can discuss it theoretically in brief. You can get a common taste, usually salt or sugar, and you should get the tongue protruded. You should use gloves and hold the tongue out, and then you put a taste. And without letting him getting the tongue inside again, he should be able to tell you what flavor he was able to taste. This is the sensory facial nerve. The last component of the facial nerve is the reflex or the reflexes, which is mainly the corneal reflex. Because remember, the corneal has the afferent and the efferent component. We are talking here about the efferent component, which is the facial nerve for the eye closure. As we saw before, he has a normal corneal reflex bilaterally in both sides. So this concludes the examination of the facial nerve, which is again motor, the muscles of facial expression, the sensory, which is the special taste, special sensation of the taste of the anterior two-thirds, and the reflexes. The next nerve to examine is the vestibulocochlear. As the name implies, it has two components, the vestibular component and the cochlear component. We don't commonly examine this nerve. I will just go through the technique to examine it in brief. The vestibular component is mainly to look for signs of vestibular disturbance. I have already examined some signs for vestibular disturbance through the eye examination. that are mainly looking for nystagmus and other abnormal eye movement that can be caused by the vestibular system. So to look for the vestibular component, you may comment about nystagmus when you examine the 3, 4, and 6 nerves. By history, there are other signs to implicate the vestibular component disturbance, but we're here talking about the examination. The cochlear part, which is the hearing, you can either use the Weber or Rene test. The technique for Weber or Rene test is through high frequency tuning fork, but you can also use the 265 or 128. I will not go through the exam technique here, and you can read it more because someone may argue the validity of these two tests. It is not the matter of discussion here, but this is the cochlear examination, i.e. the hearing examination of the cochlear nerve through Rene and Weber. You can do a very simple exam for the hearing. You can whisper at one ear and you can distract the patient very gently on the other ear, looking for if he's able to recognize the whispering in one ear, and then you can do the other side. Next exam is the glossopharyngeal and vagus nerve. We lump these two together because they share some of the features. That's why they are examined together. We do the motor part of these two nerves through looking at the soft palate and the uvula. When the patient say ah, and then I look for the contraction, symmetric contraction and elevation of the uvula and the soft palate. There is also the reflex, which is a gag reflex, and there is no sensory for these two nerves, at least that you can do through our techniques. Muhammad, افتح فمك. Okay, so now I ask him to open the mouth. I shine some light to look at the uvula and the soft palate. Muhammad, say ah. Okay. So there is contraction of the uvula and elevation of the soft palate both sides. Thank you. And both sides look symmetric. Next, you can do, and you just need to comment about the contraction and the uvula elevation with no deviation, no asymmetry. For the reflex, you can do gag using the tongue depressor. You should use the tongue depressor to touch the back of the throat in each side and looking for the gag response. I said there's no sensory exam that you can do here, but there is sensory exam, which is mainly the sensation of the soft palate, but we don't do this commonly as in clinical practice. It is mainly the gag reflex that can touch the afferent and the efferent part of these two nerves. Next exam is the accessory nerve. Accessory nerve has only a motor component. There is no sensory, there is no reflex. Now I will show the accessory nerve, which supplies two important muscles, the trapezius and the sternocleidomastoid. I'll examine the trapezius now. Muhammad, relax كده. اسمع ارفع كتفك على فوق. ارفع فوق. نزلها. So this is shoulder shrugging. ارفع مرة ثانية. So there is symmetric shoulder shrugging. نزلها. So shoulder elevates symmetrically with symmetric shoulder shrugging. And now I will apply resistance. Muhammad ارفع فوق. قاومني. Try to resist me. Resist me. Very good. Thank you. So this is the trapezius muscle, which is normal. Next will be the sternocleidomastoid. I will examine the right sternocleidomastoid. محمد بك طلع على اليسار. طلع على اليسار. So this is the right sternocleidomastoid. The function of each muscle is to deviate the head contralaterally. I will apply resistance to see how strong the muscle is. محمد حاول طلع على اليسار. أنا لا تخلي دفيتي على الجهة اليمين أنا. قاومني أنا هناك. So I'm examining the right sternocleidomastoid by resistance, pulling the head to the right, which was very strong. Now I'll do the other side. Again, this is the left sternocleidomastoid. محمد قاومني دفنت على اليمين. This is the muscle, and he is able to resist me with no difficulties, and the resistance look equal in both sides. So it is a normal sternocleidomastoid bilaterally. So this is a normal accessory nerve. The last cranial nerve is the hypoglossal nerve, which is only a motor nerve. It is the motor of the tongue, and I'm going to show the exam now. محمد الآن اسمع افتح من فمك كده. Yeah. So now I inspect. خلي فمك relax, tongue relax. Exactly. افتح فمك. So this is my inspection. I look at the tongue. I look for any signs of wasting, any fast circulation, or any atrophy or changes that I can see on the tongue by inspection. الحمد لله طلع لسانك برا. So I ask him to protrude the tongue. Tongue protrusion. It looks midline. There is no deviation. محمد حاول تحرك لسانك يمين يسار. تمام. So again, thank you. The tongue moves to side, looks equal. Now I will apply some resistance more or less to assess the power of the tongue. محمد دخل لسانك من جوا. Try to hit my finger بقوة. So I'm resisting the tongue, which looks يعني good bulk. The other side, exactly. Thank you. So this is the hypoglossal nerve, which is only a motor component and which was normal. So by this, we concluded the examination of the cranial nerves. We went through them all from number 1 to number 12. You should take at least maybe 5 minutes, 10 minutes, depends, to do them quickly. Make sure you are always organized and make sure you do it on a method using a system. Next exam is the motor examination, which is a very important part of the nervous system examination. By examining the motor system, you should do inspection, tone assessment, the power, and the reflexes. What we'll do here is we'll examine the upper limbs and then we'll do the lower limb examinations. So this is a very good way to assess the motor in the upper limbs. I will start with the inspection. Make sure you have a good exposure of the subject. I have a very decent and very adequate exposure. You can sometimes go up to the shoulder, but this is a very decent exposure here. I will inspect now. Always remember to compare both sides. So by inspection, and I'm looking here, so there is no muscle wasting that I can see. I'm looking for muscle wasting. Again, there is no muscle wasting. There is no abnormal movements or muscle contractions, and I don't see any fasciculations. I have to look for fasciculations even in more details. Mohammed, relax. So I'm looking for fasciculation here. I don't see any fasciculations. Again, I can induce fasciculations, but I don't see any. Okay, and no abnormal postures and no abnormal movements again. So by inspection, it is a normal motor exam by inspection. Next will be the tone examination. The first thing to do is you have to get the subject to relax. Muhammad, relax. So he's relaxed, and when I do the motor, the tone, I will go from the top and I'll go down. So I have to assess the muscle tone at rest. Muhammad, relax. He's really relaxed. I have to compare. Muhammad, relax again. So this is the shoulder, and then I do elbow movement or muscles around the elbow, and then supination, pronation, wrist rotation, and then I try to do finger flexion extension. So he was relaxed. This is a normal tone. There is no either increased tone or reduced tone. There is no hypertonia or hypotonia. To be more specific when you examine the tone, I will look now for spasticity and I will look for rigidity. I will start with spasticity. Muhammad, relax. Remember, spasticity is speed dependent, velocity dependent, and it's only unidirectional. In the upper limbs, you should be able to elicit it with extension. Relax. And it is velocity dependent. I have to apply speed. Relax. So it is nice and smooth. I don't see any catch. I don't see any increased tone when I apply this quick movement to the elbow. Relax, relax, relax. Okay, so relax. I'll do the same for supination, pronation. There is no spastic catch. There is no increased tone with speed. Relax, relax. So there are no signs of spasticity. Now I will look for rigidity, and it is simply the way that you do when you examine the tone. Relax. Now I'm looking for rigidity. So rigidity doesn't need any speed, and if you see any rigidity, it will be bidirectional, either, which I mean in flexion, extension, in contrast to spasticity, which is only extension in the upper limbs. So I'm looking for rigidity now, and there is no rigidity. So this is a normal tone examination, no signs of spasticity, rigidity, or hypotonia. Next exam is the motor examination, and as I do the exam, as I did with the tone, I have to start proximal, and then I go all the way down distal. This is also true for the lower limbs. محمد ارفع يدك كده. So I will start with shoulder abduction, and at least he's able to lift both shoulder up, which means the power is at least 3. Now I have to put my resistance to see is it 4 or 5. Muhammad, lift it up to let me push it down. Okay, push up. Very good. So it is full resistance, full power. The grade is 5 out of 5. Muhammad, and elbow flexion. Exactly. So this is the elbow flexion. I'll do the same. Muhammad, pull toward you. It's very strong. Pull toward you. This is very strong, and this is the power of 5. Again, I start proximal, and you compare each time, each side. Now, Muhammad, push my hand, push down. It's elbow extension, which is very strong. Elbow extension, which is very strong. Now you can extend both arms and lift put the wrist up. So this is wrist extension. Again, at least 3. I have to apply my power to look at exactly the grade. This is full, this is 5, Muhammad fog. This is 5. Now the other way around, Muhammad, so this is wrist flexion. Again, it's at least 3. Let me see, is it 5 or 4? Up, strong. Push up, strong. So this is a 5. Now finger extension. Muhammad, fingers up. No, both, yeah. Finger up, finger extension. Tamam. This is full power. Now finger flexion. Pull me, pull. So this is strong. This is strong. Thank you. So I examined the power, started proximal, and then I went all the way down to distal. The power were symmetric, and they were 5 out of 5 bilaterally. So he has a normal power examination. The last part is I will do the reflexes. In order to do the reflexes, in the upper limbs, we do have 3 reflexes that we should do: the biceps, the brachioradialis, and the triceps. For any reflex, make sure you expose the muscle of the interest, you locate the tendon, and you look at the muscle, and then you hit. I usually recommend this long rubbery hammer, because when you do the reflex, you don't want to hit directly. You want the hammer to go smooth by itself. So this is because this is rubbery, it can really go bounce, hit very gently, instead of you hit forcefully. I will show the examination of the reflexes now. Again, so I will start with this position while he's sitting. With this position, I can do the 3 reflexes all at once. So I will start with the biceps on the right side. The muscle is exposed. I try to locate the tendon. Muhammad, relax. You should always get your subject to relax. Muhammad, relax. Berkhi. And then hit. Muhammad, relax. I can feel the contraction, and you can see it. If it doesn't look as dramatic or marked as you think, you can augment or enhance the reflex, or do some technique to augment the reflex. Muhammad, go, and you can see it even more. Relax. So this is the biceps. The grade here is about 2+. I was able to elicit the reflex even before augmentation, but I asked him to augment it to make it easier for you to observe it. Again, for the other side, the biceps, the muscle is exposed. I look at my tendon. Muhammad, relax. No, relax. Ask him to relax, and you can feel the contraction. You can do the same, Muhammad, augment, right? And you can feel it a little bit more. So this is the bicep on the other side, which is normal. Grade 2, 2+. Brachioradialis is the muscle that flicks the elbow, and I can show you the muscle. Lift up, fog. So this is the muscle, and you can see it goes all the way to the medial aspect of the forearm. So at least I can hit here. Here's the tendon. Again, so I expose the muscle. I look at my tendon. Muhammad, relax. Get him to relax. And you can see the muscle contracting. Now the other side is, this is the muscle, expose it. I look at my tendon. Muhammad, relax. Relax. And you can see there is some contraction. Even sometimes if there is wrist extension, because of the brachioradialis contraction, don't look at the wrist extension, look at the muscle. Because this is a brachioradialis muscle, it is not a reflex, it's not wrist extension reflex. The last upper limb reflex is the triceps. Relax. So it is exposed, and I can see it here. Thank you. So it is exposed. I locate my tendon. You can hit on the tendon directly without putting your finger. Ahmed, relax. And you can see the contraction, and he can feel it and he can see it. The other side, I will expose. Relax. And it is there. There is another way to do the reflex for the upper limbs to make it easier. Ahmed, relax. I expose the muscle. Relax. I look at my tendon, and you can see the contraction. Don't look at the elbow extension. Look at the triceps, because the triceps reflex. And you can do the same with the other side. Relax. Thank you. You can also do another small reflex, which is not commonly done, which is the finger flexion reflex. Ahmed, relax. So I get, this is the finger flexors. I get the fingers to flex. You can see it. When I hit, he goes finger flexion. Yeah, I can feel it. Ahmed, relax. This is another easy reflex to get. You may get used to do it. One more reflex that you may do in the upper limbs, which is looking for Hoffman sign. Hoffman is an equal test to the Babinski in the lower limbs. It's a sign for an upper motor neuron lesion. Relax. So you didn't see anything, which is normal. So the brisk finger flexion with Hoffman is pathological indication of an upper motor neuron sign. Relax. So you didn't really see that much of finger flexion. So pathologically, again, you will look for very brisk, exaggerated finger flexors. We concluded the motor examination through the inspection, tone, power, and reflexes, and Muhammad has a normal motor examination in the upper limbs. I will quickly now demonstrate the examination in the lower limbs. I will now demonstrate the motor examination of the lower limbs. Ideally, it should be on the right side of the patient, but I will do it here on the left side just because of demonstration. Again, I will follow the same system. I will do the inspection, tone, power, and reflexes. I will go without explaining the steps that I'm doing. So by inspection, he's exposed fully. You should get even more exposure, but this is ideal, this is adequate. We're looking for, again, no wasting, no fasciculation that you can see. No abnormal postures, no abnormal movements. Next is the tone. Ahmed, relax. The tone examination, get him to relax. This is normal tone. This is also looking for rigidity. There is no rigidity. There is no rigidity with normal tone. I want to examine now spasticity. Ahmed, relax. There is no spasticity. So normal tone examination, the lower limbs. Next is the power. Start with the right leg. Ahmed, اثني ركبتك. اسحبها عليك كده. All the way. اسحبها من عليك. Try to resist me. So I will apply resistance. This is normal hip flexion with the other side. Ahmed, resist me. This is normal hip flexion on the left as well. I will do now hip extension. Ahmed, push down. اضغط تحت تحت. Hip extension of the left is normal. اضغط تحت. On the right is normal. The other way to do it is to get him to flip over and then extend the hip. But what I did is still adequate, and he has a normal hip extension. I'll do now knee flexion. حمد اثني ركبتك. Pull it toward you. اسحبها عليك. This is normal knee flexion. Now مد رجلك على فوق. This is hip knee extension, which is normal. With the other side. اسحبها عليك. اسحبها اثنيها. So left knee flexion is normal. Extended. Knee extension is normal. Now we'll go down to the dorsal flexion, plantar flexion. Ahmed, the ankle, pull it up exactly. So at least looking at the ankle flexion, this is at least 3. We'll try my resistance to see what it is exact grade. Ahmed, pull toward you. This is very strong. Pull toward you. This is very strong. So this is normal. Ahmed, now go the other way around, down. This is plantar flexion. Again, Ahmed, pull, push down. This is normal. Push down. This is normal. Relax. Thank you. So he has a normal motor examination of the lower limbs. Again, I started proximal and then I went all the way down to the distal. Next is the reflexes. I have 2 reflexes to examine, as well as the Babinski sign. I'll examine the knee reflex and the ankle reflex. For the knee reflex, expose the muscle as if it is exposed, as it should be exposed. Get him to relax. Get him to relax. This is the tendon, and you can see the muscle contracting. You should look at the contracting muscle, not the ankle, not the leg or the knee extending. To the other side, exposing the muscle, adequate, relax. You can do this, we commonly do this, at least you secure he's relaxed. Ahmed, relax. I have the knee tendon exposed, and the muscle ideally should be exposed. Relax, and I look at the muscle. So this is ankle, the knee reflex, which is symmetric. Now for the ankle, we usually do triple flexion. So I flex the hip, I flex the knee, and some gentle flexion of the ankle. It's just a gentle flexion. Expose the gastrocnemius muscle, then I hit. And you can see very nice and easy elicited reflex. I do that. It's the same for the other side. Some hip flexion, knee flexion, and a gentle ankle flexion. Relax, don't help me. Gentle ankle flexion, and you can see the muscle contracting. Thank you. Finally, I have to do Babinski sign, which is an upper motor neuron sign, which equals to the Hoffman in the upper limbs. And for the Babinski, you have to scratch, gentle but yet adequate scratch of the sole of each foot. You come from lateral and go all the way medial, and you look for response or no response. The normal response is flexion of the big toe and the other toes. Pathological response, which is positive Babinski, is what we call upgoing plantar, or the upgoing flexion of the big toe, or dorsiflexion. We'll examine this now. Ahmed, relax. I'm going to scratch the foot.
Okay.
Sometimes you have to give the patient some hints because it may be a little bit annoying to some patients. Ahmed, relax, Ahmed. So from lateral, I go all the way medial. And if you look at the toes, they went down. You can do it again to confirm. And the big toe even goes down. Sometimes it stays the same, which would be this is what we call equivocal. It may have no clinical implication, but definitely if it goes up, it is pathological. I will do the other side as well. Relax, Mohammed. So it goes down or equivocal. So this is a negative Babinski, which is a normal response. So again, the motor examination of the lower limbs were normal for the inspection, for the tone, for the power, and the reflexes. The next examination of the nervous system is the sensory examination. Sensory examination is a little bit tricky because you have to know the technique properly, and it really depends on the patient's response. We have different sensory modalities that we should look for. We examine pain and temperature, we examine vibration and proprioception, and you can also do the touch. I will quickly go through these sensory modalities with different techniques. I will do the upper limbs first, and then I will quickly demonstrate the lower limbs. I will start with pain and temperature. For pain, you can use the toothpick, which would be sharp, disposable, that you can use it once and then you throw it away. Try to avoid needles because you may, first of all, you may injure a patient or a subject, and you don't want to spread whatever this subject is having to the other subject through blood needle stick. So we'll always use a disposable toothpick. Here I will do temperature for the pain. It is the same thing. For temperature, you can use any cold or hot item. Usually cool is better than hot because it is better tolerated by the subject or by the patient. I put this in ice water, and it is now cold. So I will use it as my cold instrument to examine the temperature. I will again examine the upper limbs, and then I will do the lower limbs. You have to always start with control, like an area that you teach the patient what is to expect as a sensation. Because I'm examining the upper limbs, I can use either the forehead or the chest as my control. Mohammed, you feel this? Is it cold?
Yeah.
Yeah, it's cold. So now, you feel that, خلاص?
Yeah.
طيب. Now, close your eyes. You have to get the subject or the patient eyes closed because this is sensory. I start distal and then I go all the way proximal. Mohammed, you remember the temperature, and
Yeah.
you learned it now. I'm going to examine the limbs starting with the hand, okay? And I will do both sides. Okay? So, feel it cold?
Yeah.
Yeah. Is it cold?
Yep.
Yeah. Is it cold if I go up?
Yeah.
It's still to be cold. Did it change?
No.
Okay. Now we'll do the other side. Again, I start distal. Is it cold?
Yeah.
Yeah. If I go up, is it
Yes.
getting any cooler or different or the same?
Same.
It is the same. So thank you. So this is a quick screening way to look for temperature sensation. Normally, he should be able to feel the same degree of cold sensation as in the control. And when I put it on his arms, it will be the same feeling from distal all the way to proximal. Pathologically, you may find increased sensation of the temperature as I go more proximal, because usually sensory abnormalities, the most common pattern is distal more than proximal involvement. So this is the pathological response, but here this is a normal subject. He has the same cold temperature distal as well as proximal, and similar to the control. If you want to do a sharp item with a toothpick, you can teach him the control first, either forehead or chest, and then eyes closed, and then you feel you run your sharp item distal to proximal, looking for the same response or more pain if you go more proximal, and you should compare right to left. The next modality is vibration and proprioception, and I will do now vibration in the upper limbs. For the vibration sensation, you can use 128, 265 or 512 frequency tuning fork. I'm using here 128 tuning fork. Again, to start with, I have to do my control first, and then I'll go to my area of interest. When you use the tuning fork, make sure you hold it from the handle. You don't hold it from the fork itself, because you will kill the vibration if you hold it this way. So the correct way is to hold it from the handle. Now, I will show you the exam technique now. Muhammad? ايش تحس؟ Vibration. اهتزاز vibration. تمام. So now I'm going to examine the arms. Can you close your eyes? So he know now what to expect, which is a vibration. Make sure he feels the vibration, not the pressure. Not the pressure pushing the skin. It is a vibration, and he was able to recognize the vibration. Muhammad? So ايش تحس الآن؟
Vibration.
طيب. Tell me when it stops. I feel it, he feels it. Muhammad, do you still have it?
Yeah.
I still feel the vibration. I'm comparing my threshold to his threshold.
It's a stop.
Stop now?
Yeah.
And it stopped in my hand. So again, my threshold is comparable to his threshold. It stopped at the same time he felt it that it stopped, which means a normal vibration threshold, which means normal vibration sensation distally. For the vibration, once it is normal distally, you don't have to go proximal, because it is going to be normal proximal. Again, usually the sensory abnormalities start usually distal and then start to affect proximal. I should compare the other side. Muhammad, do the same side. So I'm putting my tuning fork on a bone, distal digit. Muhammad, feel it?
Yeah.
And I still feel it?
It's a stop now.
And it stopped as my feeling. For the pathological vibration sensation, patient may have impairment to the vibration distally, and then you should go proximal. Whenever you go proximal, always make sure you put your tuning fork over a bone, because remember, vibration runs through a bone. So if it is impaired here, I go over the wrist, over a bone, I go over the distal forearm, and then mid forearm, and then the elbow, and so on, until I get to the area where his vibration threshold is equal to mine. And then I would say there is an impairment vibration sensation up to whatever level you picked. But here I do have a normal vibration sensation bilaterally. The last sensory modality that I'm going to demonstrate here in the upper limbs is the proprioception, or the joint position sense. Muhammad, open your eyes. Usually you have to do it at the distal. When you hold the finger or the toes, when I show you the lower limbs, hold it from the sides, because you are going to flex and extend the distal part of the finger. If you hold it from here, he will be able to feel the pulling of the tendons. but if you may hold it from the side, this is very important, you may minimize this mechanical impact on the finger movement. أحمد شوف الآن هنا. Look at this. This is the movement down.
Okay.
This is up. خلاص. I'm going to move the finger here. Close your eyes. So again, his eyes are closed. Now.
Down.
Okay. Now.
Down.
Now.
Up.
Now.
Down.
Now.
Up.
Now.
Up.
Okay. You should be able to do few random movements, and he should be able to pick all these movements. He was able to pick all the movements, so this is normal proprioception on the right. I should do the same on the left. Hamad, again, the hold from the sides. Hamad, will do the same here, huh? Now.
Down.
Now.
Down.
Now.
Down.
Now.
Up.
Now.
Up.
Again, you try to be random. He was able to pick all the movements. Sometimes because he was able to pick the large movement, we may, and if you suspect there's an impairment of the vibration and proprioception sensation, you may do a small movement. We'll do it again. Now.
Down.
Now.
Down.
Now.
Up.
Okay. And he will be able to elicit and pick all these movements. If he is impaired at the distal, at the fingers, you should do it over the joint, because it is a joint position, and you can do wrist. If he's normal, that's it. If he's impaired, you should do over the elbow. It's uneven over more the shoulder. It is uncommon to find impairment more proximal, but you may see it. Make sure you give a comment at the level where he was able to recognize the movement over whatever joint you examined. So here now we have normal vibration, normal proprioception sensation bilateral in the upper limbs. There's a normal pain and temperature. You can screen for touch using a tissue paper. Teach him the control first, and then close his eyes, and you can just run your tissue paper distal to proximal, looking for the same movement, the same sensation, distally to proximal. And I'm not going to demonstrate it because this is easy to explain and easy to do. I will now demonstrate the sensory examination in the lower limbs. I will do it very quick because we have done it already in the upper limbs. I examine pain, temperature, vibration, proprioception. I will start with the temperature. This is again cold. Ahmed. This is my control. Barda.
Yeah.
Cold. Again cold.
Yeah.
One of them is enough. I will do both. Now close your eyes. I will start distal and then go proximal. Ahmed. Cold.
أيوه.
Cold.
أيوه.
If I go up,
أيوه.
the same temperature.
Yeah.
It's not getting colder or warmer,
No.
and you have to go up. يعني for assuming he had exposure, but this is adequate exposure, so it is the same temperature. Mohammed.
Yeah.
We'll do the other side. Mohammed, close your eyes. I start distal. Mohammed, cold.
Yeah.
Cold.
Yep.
Is it the same if I go up?
Yep.
It is not getting cooler or warmer. No. Thank you. So this is a normal temperature in the lower limbs. I can do the pinprick again with a sharp toothpick. Get to the control. He feels it sharp, and then his eyes are closed, and then I go distal, and I just keep poking him gently, of course, to look for the pain sensation that should be the same throughout, from distal to proximal, as well as on the control area. Vibration, I will do the same quickly. لا افتح عينك. What do you feel?
Vibration.
Vibration? Okay, now we'll do it in the lower limbs. Close your eyes. I will go at the toes distally. You feel it?
Yeah.
And I still feel it. You feel it, Mohammed?
Yeah.
I still feel it.
Stop now.
Stop now, and it stopped actually. So this is a normal vibration threshold. I should do the other side. Mohammed, the same story, you know?
Yeah, it's vibration.
You feel it?
Yeah.
Sometimes people may try to get this stopped. I prefer to go that the vibration, the tuning fork will go stop by itself.
Stop.
Because thank you, and it stopped actually.
Yeah.
You are not looking at if it stops or not. You look at the smooth stop of the vibration itself. Sometimes you may read there is a normal response of 8 seconds plus or minus. The idea here is to compare your vibration threshold to his vibration threshold. So this is a normal vibration. I don't have to go any more proximal. Next is proprioception. Mohammed, بس بقطع معايا. هنا I will move the toe. Again, I'm holding it from the sides. Mohammed, this is up.
Okay.
This is down. Now close your eyes. Close your eyes, Mohammed. Now.
Down.
Now.
Up.
Now.
Up.
Now.
Up.
Okay. Now.
Down.
So this is a normal proprioception. If you suspect a proprioception impairment, you can do a fine, smaller movement, as we have done already on the upper limbs. I will do the other side. Mohammed?
Down.
Okay. Now?
Up.
Now?
Down.
Now?
Down.
Okay, so this is a normal joint position since on the other side. If it's impaired, if it's normal distal, you don't need to go anymore proximal. If it's impaired distal, you can go at the ankle. If it's impaired, you can go at the knee, which is very unlikely, very uncommon to find impairment. But you have to do the proper technique in order to pick all these signs. For the touch, you can use tissue paper. Go to the control and then eyes closed, and you try to slide your tissue paper distal to proximal, bilateral, both sides, looking for the same sensation or different sensation. And this is the sensory examination in the lower limbs. So he has a normal sensation in both upper and lower limbs for the whole sensory modalities, or for all sensory modalities. The next part of the nervous system examination is cerebellar and coordination examination. For the upper limbs, there are a few exams that we do, and in the lower limbs, there are different exams that we should do. So for the upper limbs, we usually do finger nose. We look for rapid alternating movement. We examine finger tracking. We also look for rebound phenomena. I'm going to demonstrate these signs in the upper limbs. For the lower limbs, which I'm going to demonstrate as well, we look for heel shin. Sometimes we do knee tapping, and sometimes we also do toe tracking. I will start with the upper limbs here. I will start here with the finger nose, Muhammad. With your right finger, with the right hand, try to touch my finger, and then go back to touch your nose. And I need you to keep doing this back and forth, and you keep follow my moving finger.
Okay.
Make sure you move the finger at different directions, and make sure you go at distance, because if you look for cerebellar signs, usually, they are better shown toward the target, toward this distant target. We'll do the same for the other side, Muhammad. Yeah. Okay. So he was able, to accurately hit the tip of my finger, and then back to the tip of his nose. This is a normal response. Pathological finger nose exam will be ataxia with dysmetria or post pointing. He will overshoot the target, and he will overshoot his nose. So here he was very straight, accurate, no ataxia, no dysmetria. Now I will do finger tracking. Ahmed, extend your finger. Don't touch me, just try to follow my finger. So he's accurately getting to my target. He's not post pointing. To the other side. He doesn't need to touch, he just needs to follow. Okay, very good. So this is finger tracking. This is, again, I'm looking for overshooting or dysmetria. Now we will do rapid alternating movement in the upper limbs. Muhammad, starting with your right hand, I want you to tap on the left hand. Make sure you tap big distance, and then you alternate.
Okay.
Make sure he's big distance, yeah, and he's alternating. Can you do it fast, a little bit fast? Because it's a rapid, and it's an alternating movement, but big distance. And it's big distance. Thank you. Now do the other side. Big distance. So, thank you. So he's able to keep the same speed and keep the same sequence of alternation. So this is the rapid alternating movement, which is normal response. If it is impaired, the patient will show dysdiadochokinesia, which is an impaired rapid alternating movement. Dysdiadochokinesia. This is a cerebellar sign or a sign of incoordination. Next, I will do rebound. We have two ways to examine rebounds in the upper limbs. There is a safe way to do the exam, and there is not an unsafe, but you have to be careful when you do it. I will do the simple one, which is very valid, very okay to give you information that you need. Stretch both arms up. So I put both arms up. Hamid, keep it here. I will push it, but keep the arms at the same level. So I will apply some pressure on each hand, each arm separately. I'm looking for a rebound. So now he was able to, after I pushed the hand, the arm, was able to get the arm back to the same level with no overshooting, with no rebound. So this is a normal response. Pathological response, he will overshoot and then go back. So at least you have both arms up, so you have the same baseline that you compare to. So this is, thank you, this is a absence of rebound phenomena, and this is a normal response. The other way to do rebound phenomena, Mohammed, both hands. So I will protect patient's face by putting my arm, and then Mohammed, خلي يدك كده. Keep it the same, keep it at this place, yeah. Then I pull. So he's keeping the arm at the same level to the other side. So he's keeping the same arm at the same level, thank you. If he has a rebound, he will again overshoot. When I let my hand go, he will overshoot, he may hit his face. That's why you have to protect the patient's face. If you don't know how to do this technique properly, please avoid doing this because it may cause some problems to the patient and to you as well. So better to use the arm stretch rebound test. Either ways, rebound phenomena was negative by two different techniques here. So coordination exam in the upper limbs were normal. I will demonstrate now coordination in the lower limbs. I will now demonstrate the cerebellar examination or the coordination examination in the lower limbs. And we do 3 tests: the heel shin, knee tapping, and toe tracking. I will start with the heel shin test. This is very standard coordination exam in the lower limbs. Mohammed, I need you to, starting with the right foot, I need you to run the heel on the shin. You go up all the way to the knee, and then you go down. Okay. Make sure you go straight line. Make sure your toes are up. Okay. Keep it always up. You don't have to be quick. You have to be accurate. Okay. Okay. Now the other way around. Toes up. Make sure you go straight. Yeah. Okay. Thank you. So this is a heel shin examination. There is no ataxia. There is no incoordination. So this is a normal test. Next, I will do knee tapping. Mohammed, with your right leg again. Start here. Can you, in the heel, tap on the knee? Okay. Make sure you tap accurately. Okay. Yeah, you can do it a little bit quicker. So this is the accuracy of knee tapping. He tapped the knees by his heel, and he was able to do it all the time. There is no dysmetria. There is no overshooting. Thank you. With the other side now. The heel on the knee. Make sure the knee. Yep. So it is accurate knee tapping, no dysmetria. Thank you. Now I will do toe tracking. It is uncommon, but still this is a very good sign to look for cerebellum as well. Try to follow my finger with your toes. You cannot go a lot in different, area-wise because limitation. But again, he was doing it adequately. He's not overshooting. There is no ataxia. I'll do the other side. Yep. No. Very good. So at least this is thank you, Mohammed. This is a toe tracking, which was normal. So I can conclude he has a normal coordination and cerebellar examination in both upper and lower limbs. I will now show you how to look for truncal ataxia. Truncal ataxia is a midline cerebellar examination. It's a midline structure of the cerebellum. Mohammed, can you cross both arms? Try to sit up. Thank you. So this is a normal response. He was able to sit up with arm crossed, and he was very steady. If there's a truncal ataxia, he will have difficulty sitting up and stay still without supporting himself. So he will be very wobbly and he'll be ataxic. And then you can say there is a signs of truncal ataxia. But Mohammed's exam here is a normal, so there is no signs of truncal ataxia here. The next and the final examination is the gait examination. We will do a few maneuvers to look for signs of gait abnormalities. To start with, we will get the patient to walk normally, and he should walk toward you, and we should look for this distance between the feet, the swinging of the arms, and we should get him going back and forth. It's best to be examined in a corridor where there's a good space for the subject or the patient to walk. This is as an observation. You can come up with a lot of signs by only observing the normal gait. To make it even difficult, if the gait is normal, we will do tandem gait, which is heel to toe. We'll get the patient to get his toes attached very well to the heel, walk on a straight line, heads up, and he should be stable and steady when he's doing this maneuver. So this is a normal tandem gait or heel to toe walking. If somebody is unable to do this, he will be very ataxic, very difficult to do, and maybe he will be unstable or even difficult to attempt this walking technique. The next technique is I will get the patient to walk in his on his heels. So this is a good way to look for flexors, dorsiflexion of the foot, and he was able to nicely do heel walking. And we can do the other way around. We can do a toe walking, where patient will walk on his tiptoes. This is a good way to look for plantar flexion, and the subject here is able to walk on his toes with no difficulties. This is a toe walking. You can do other technique of the gait. While the patient is standing, you can look for also other signs of proximal muscle weakness. You can get the patient to cross both arms and ask him to squat, and then you ask him to stand up. So this is a normal squatting test with no signs of proximal muscle weakness, which is commonly seen with myopathy or muscle disease. Finally, while you are doing the gait examination, you should do Romberg test, which is a dorsal column problem or proprioception problem, to be more general. Ahmed, can you have both feet together? Feet close together, yeah. And then head up, close your eyes. Now I'm doing the Romberg test, and you should wait for sometimes 15, 20 seconds or maybe more to look for how steady he is when his both eyes are closed and the feet are tightly closed together. He's very steady. If you suspect proprioception or dorsal column impairment, you can make the test a little bit difficult by pushing the patient a little bit. He's very steady. There are other variations to do the exam. Put both arms. So there's another way to do the same test. You can put both arms outward at the sides, or put it in the front. You can also do the same Romberg test, both arms outstretched in the front of the subject, and it is the same idea, the same technique, the same duration that you're waiting for. Thank you. So this is a negative Romberg test. So in conclusion, this is a normal examination of the nervous system. Thank you very much for watching. I wish you best of luck. The best thing to do to use this video is to practice and to keep practicing this, whatever the degree of difficulty, no matter how difficult this looks or how thorough, how complicated. You should just keep practicing this exam, and you should have no difficulty performing it in any patient. Thank you again.